So I shall move on to. So I'll just introduce myself. I was on the panel this morning, but like I say, I'm an advanced musculoskeletal physiotherapy practitioner, and I also work as a transformation clinical lead as part of my NHS role. I also work 2 days a week as an associate clinical fellow in advanced practice at Manchester Metropolitan University. So I have a sort of a dual role. Okay, so the allied health professionals, well, who are we and what do we do? Well, allied health professionals, depends which literature you read, you might see there's 15 or 14 professions, but we're a real diverse group of clinicians. We deliver high quality care to patients across a range of pathways and in a range of settings. Allied health professionals really support the sort of modern health workforce and the social services. All allied health professionals are registered by the Health and Care Professions Council. And for myself as a physiotherapist, my professional body is that of the Chartered Society of Physio. So in preparation for this talk, I was really trying to think about what is the difference between an AHP advanced practitioner and a nurse practitioner, and we've discussed that this morning, which so I won't go into too much detail around that. But of course, advanced practice is a level of practice, and of course, all professions have their sort of special areas really. But looking at the sort of different frameworks across the countries, I was really interested to see sort of the Northern Ireland and Scotland have an AHP advanced practice framework, whereas Wales and England more multi-professional. But looking at the documents, those have very, very similar core content and capabilities. So my role, so like most roles, the advanced musculoskeletal practice role started or came about really from the introduction of the Working Time Directive in 1993. As we know, this led to a reduction in doctors' hours, gaps in NHS services. At that time, MSK physios started to extend their skills. We started to develop more advanced clinical practice reasoning, knowledge, and also diagnostic skills. Around this time, we also gained the rights to provide musculoskeletal injection therapy, so corticosteroids and local anesthetic injections. And then this followed with changes in legislation to allow us to become non-medical prescribers, first supplementary, followed by independent. So for me, in my role, my educational route to advanced practice has been really through a portfolio role, part educational and lots of experiential type learning. Okay, so what is the role? So obviously we see musculoskeletal conditions, so low back pain, shoulder pain, neck pain, all of those things, and also rheumatological conditions, fractures. We're autonomous practitioners and have a very much a diagnostic clinician role, working with patients who present to us with undifferentiated, undiagnosed problems. We use our advanced clinical reasoning skills and knowledge and our knowledge of multiple comorbidities to help us form diagnosis. We manage the complexity and uncertainty, and we work across a range of the patient pathways. So you'll see us in primary care, in ED, in interface services, but also in secondary care services. So our role includes assessment. So obviously, like everyone, we perform clinical examination. We're screening for potential serious red flags, but we're also gaining a history to help us form a hypothesis of the clinical diagnosis. Our objective assessment includes lots of physical tests where we're testing structures like tendons and ligaments for their integrity and joints for range of movement. It might be that following our clinical examination, we feel we need further diagnostic tests, and we usually have within our remit the ability to order MR scans, X-rays, ultrasounds. If we think somebody has any neural issue, such as carpal tunnel syndrome, then we may choose to refer for nerve conduction studies, and then also blood tests where we're checking for any underlying systemic conditions or in systemic inflammatory disorders. Once we've got our clinical diagnosis, we review the management. And of course, management is underpinned by evidence-based practice and evidence-based pathways. We take the opportunity to make every contact count. So we include social prescribing, try and adopt a personalized care model. We advise on exercise and lifestyle. It may be that the patient requires medications for pain relief, so we can prescribe these as non-medical prescribers. It may be they need a corticosteroid injection into knee, and we perform that. If the patient is extremely complex, it maybe they need to have a different system as a primary problem, then we may refer back to GP. If we identify serious pathologies, we'll refer on a 2-week wait cancer pathway. And then we also act like a triage service. So we can refer patients for treatment, so physiotherapy, podiatry. We also can refer patients for review for surgical opinion, or if they're very complex, to some of the secondary care services, typically orthopedics, rheumatology, neurosurgery. So the impact of our role, and it was talked about this morning, the importance of the impact, and it's been shown really having advanced MSK practitioners, this enables cost savings across the MSK pathway. There is more effective triage of patients, more effective use of diagnostic tests, and of course there's increased capacity for MSK conditions. Our capabilities, of course, align to the capabilities of the multi-professional framework across the 4 pillars of practice, and our more advanced MSK-specific capabilities can be found within the first contact and advanced practice roadmaps, and these align to the international orthopaedic standards. So the forgotten pillars. Okay, so in my role, in my NHS role, I have a role in sort of transformation. The trust I work at is a newly created single hospital service. It's formed together from the merger of previously separate NHS trusts. We're now responsible for 10 trusts, and we're one of the largest acute trusts in the UK. The team that I have a clinical leadership role for is a musculoskeletal team, and it's a new team that's been created from the merger of previously 4 separate hospital teams. The merger led to variation in MSK services across the team, so variation in clinical pathways, policies, templates, patient access. So my transformation role was to safely integrate and harmonise the work of the team. Other factors, though, that have impacted on the role have been the introduction of the first contact practice roles in primary care, which is putting a clinician with advanced clinical skills at the front of the patient pathway. So that has been a change. Also, we have the requirement for first contact practice and advanced practice verification for the Centre of Advancing Practice. So this is part of my sort of remit for the team. And of course, like everybody, we've got the challenges, but also the opportunities that have come for MSK service provision in restoration of services in a post-COVID world. In terms of transformation, we did a big scoping and engagement exercise. We identified 18 work streams, which you'll see here, and part of the transformation work has been developing small task and finish groups to carry out and implement the work. So for me, the pillars are blended, which was what we talked about this morning. So for me, the leadership, management, education and research pillars are all blended together. In terms of leadership, we're introducing a lot of the changes. We've used a transformational leadership approach, and also being reactive and self-aware, using self-awareness capabilities to manage people through the emotional response of change. So helping out and supporting our practitioners through the different aspects of change. So some people who are really on board are early adopters, whereas there are other people who may take a little bit more time. So being, as an advanced practitioner, using flexibility within your leadership to enable support and to support the team through the changes. In terms of education, we provide education at most patient consultations, so that's as normal practice, but also in terms of ACP supervision. Of course, I work 2 days at the university teaching across the multi-professional advanced practice apprenticeship, and I'm also one of the national trainers for first contact practice supervisors. In terms of research pillars, everything that we do is evidence informed. Our pathways are evidence informed. Our decision making around which clinical tests is evidence informed. Our quality and service improvements that we've done as part of the transformation, they have been evidence informed, even to the point of considering stakeholders and the different tools we can use for stakeholder analysis, different tools we can use for quality improvement, different project methodologies. So at every point, considering the evidence, having a critical eye and making a judgment of how we're going to apply that in practice. In terms of publications, I did publish my dissertation from my master's, so I had a publication there, and I've had some conference presentations and abstract, including this one. So I have some other responsibilities. So at my trust, I've recently just taken on a role and part-time as a seconded role, just to coordinate some of the trust advanced clinical practice developments. I also co-chair our Greater Manchester, which is our local ICS ACP strategy group, and I have executive membership with AAPE, which is wonderful, and the Advanced Practice Physiotherapy Network. So these are how I embed my capabilities across the 4 pillars of practice. So I hope that's given you a bit of an insight into an advanced MSK physiotherapist. Thank you. And if any questions, please pop them in the chat.